everyone. I'm Dr. Stanley Schwartz, and I'm a speaker for today's webinar. The session will be for about 30-40 minutes, followed by a question-answer session for about 10 minutes. Note down your questions and queries and ask me questions through that mechanism in the question-answer session. Let's start with today's topic. The diabetes syndrome, a logic for implementing precision medicine. And we can start. So the key here is we're discussing the diabetes syndrome, a logic I've created for implementing precision medicine. And it'll provide a framework for understanding and managing diabetes today and in the future. And we use it a unified pathophysiological approach based on our beta cell classification of diabetes, which I published several years ago. That article has been cited by 300 other articles in the past few years, which is apparently a very large number. And I'm happy to share the principles with you today. So the key observation I came upon was that our current diabetes classification is failing. It's outdated. It's based on a narrow view of pathophysiology. For example, type 1 diabetes is an autoimmune destruction of the beta cells. Fine, correct, but 30 to 50% of patients with type 1 diabetes also have insulin resistance. Type 2 diabetes is felt to be insulin resistance related, but 15, maybe even more, 20% of patients with type 2 diabetes have islet cell antibodies, typical of autoimmune destruction of beta cells. Other examples is flatbush diabetes. It presents as DKA, but it turns out to be type 2 diabetes. LADA, latent autoimmune diabetes, the adult, are adults who look like typical type 1 diabetes on the thinner side, but they have genes for type 1 and type 2 diabetes. We've learned so much more. So in my article, we suggested that all diabetes should be discussed in terms of a beta cell centric approach. And it's due to 4 basic pathophysiological mechanisms: genes, environment, inflammation, and insulin resistance. Okay. So the genes, polygenic, monogenic forms affect the beta cell through multiple mechanisms. The gene interact with the environment, and the environment reflexively interacts with the genes. That's called epigenetics. And environment can affect insulin resistance and inflammation. And the genes can directly affect insulin resistance, directly affect inflammation. And the summation is all these pathophysiological processes affect beta cell function. In terms of genes, genes are mapped to type 1 diabetes, but of course, patients with type 1 diabetes can also have type 2 genes. Here you can see type 1 genes that are immune-related and non-immune related to insulin and beta cell function. We need to know the pathways engendered by the different genes, and ultimately the markers that these genes reflect or are reflected by the genes. And then we'll need a compendium of genes pathways to match the compendium of potential pharmacologic agents and pathways that they address. On the type 2 side, you can see type 2 genes can be insulin secretion, insulin resistance, BMI related, insulin related, and be aware that of all on the right, secretory dynamic pathways and the genes that they may be involved. But of interest is of the genes mapped to type 2 diabetes, only about 15 to 35%, depending which article you read, account for the heritability of type 2 diabetes. So the rest of the heritability of type 2 diabetes might be related to epigenetic changes. And this is where environmental factors, you can see on top, hypoxia, pollution, low nutrient availability, maternal factors, smoking, maternal diseases, alcohol, drug addictions, placental factors, fetal factors can change DNA by multiple chemical mechanisms: cytosine, variant histones, histone tail modifications, increased RNA, microRNAs, and they affect the genes. And it's been shown that these epigenetic factors cause diabetes. Of interest, fuel excess is a major issue. You can see that through pregnancy, and that can affect the risk of diabetes in the fetus in the future. And then we can talk about the environment. Environmental issues include the fuel excess story, but gut biome, advanced glycosylation end products in food, endocrine disruptors, and viruses. In this regard, exogenous fuel excess is a major factor in the risk of diabetes. It can affect the brain. The loss of the dopasurgeon, the suprachiasmatic nucleus, increases centrally induced peripheral insulin resistance. And I'll show you a slide in that regard. Exogenous fuel excess causes insulin resistance, affects the gut biome, which alters endothelial permeability in the gut, causes increased insulin resistance, and adversely affects insulin secretion. Exogenous fuel excess causes hyperinsulinemia. And Barbara Corky says it affects altered beta cell function, decreases insulin, increased glucagon, increased GLP-1 resistance. And this exogenous fuel excess can cause epigenetic changes. Here you can see in terms of environment, some foods are good for you, eliminate inflammation. Some foods cause inflammation. And then dietary patterns can affect the microbiota pattern in each individual. And that affects low-grade inflammation, secretion, and insulin resistance. Physical activity also affects these processes as well. And this is all environment related. If we talk about the inflammation, you can see that beta cells are destroyed by innate and adaptive immune reactions, innate macrophages and cytokines, adaptive T-cell antibodies. And on the right, you can see that the same processes that inflammatory processes that affect the beta cells in type 1 also affect inflammatory processes in type 2 patients. We can then talk about insulin resistance. There's classic peripheral insulin resistance, muscle, liver, fat, but there's central induced resistance, there's stress hormone induced insulin resistance, and there's gut biome induced insulin resistance. In terms of central induced insulin resistance, it's a loss of dopamine surge in suprachiasmatic nucleus, increased appetite, increased sympathetic tone, and that can affect the peripheral insulin resistance. And you can see the contributions of biome resistance, inflammation-related insulin resistance. And guess what? There are drugs for each kind of insulin resistance that are available to us. So just because you have, I have this drug to treat insulin resistance, it doesn't mean you can't use other drugs that works against other mechanisms of insulin resistance to help the patient. And insulin resistance on the right is determined by genes, exacerbated by the environment, the diet, activity, the biome, and beta cells are particularly vulnerable to insulin resistance. And insulin resistance impairs beta cell function by lipo and glucose toxicity, inflammatory mechanisms, adipocytokines. Central resistance illustrated here: Western diet, psychological stress, altered sleep-wake cycles, antipsychotic medications, decreased central dopamine, that's the biologic clock, and that can result in increasing VMH, norepi, serotonin, PVN, NPI, CRH, which increases chronic sympathetic nervous system overactivation. And you can see the multiple things are affected by increased sympathetic tone: hepatic glucose output, hyperinsulinemia, increased adipose lipolysis, hypertension, visceral obesity, oxidative stress, inflammation. This results in type 2 diabetes, increases target organ damage, increases cardiovascular risk. And this can be reversed, by the way, by a drug that's on the market, bromocriptine quick release, not the bromocriptine long-acting used for pituitary tumor therapy, but bromocriptine increases dopamine surge first thing in the morning, just like the normal patient would have a dopamine surge, and counteracts the processes seen in the rest of this slide. And the pathophysiologies we had mentioned, genes, environment, insulin resistance, inflammation, result in multiple mechanisms of hyperglycemia. I went further than our friend Ralph DeFranzo, ominous octet, and I created the egregious 11. You have the one core defect, which is the beta cell. Never forget that. But you have 6 mechanisms of damage to the beta cell. It's resistance, liver, adipose tissue, muscle. You have the colon biome. You have the brain, and you have immune dysregulation, inflammation. And you have 5 downstream effects of damage to the beta cells: reduced insulin, reduced incretin effect due to GLP-1 resistance, increased glucagon, reduced amylin, which increases rate of stomach absorption, emptying and absorption from small intestine of glucose. And you have abnormal kidney function that can result from the hyperglycemia that results from everything above. And you'll eventually, and I'll repeat this later, treat the most number of mechanisms of hyperglycemia, just that we reviewed, with the least number of drugs. And in this sense, we submit this as a more rational and accurate approach. We'll classify each patient by the specific cause of the beta cell dysfunction in that patient. That resulted, by the way, in varying clinical presentations, specific phenotype, and then we'll apply personalized treatment, precision medicine, which is targeted therapies aimed at the specific pathophysiologies and each mediating pathway of hyperglycemia at work in that patient. Now, in an article just published, there are common phenotypes that exist. You can see that here. I'm not going to read it in detail, but this is, if you will, too simplistic. It doesn't address the variations that I implied exist by the multiple genes, the multiple types of insulin resistance, the multiple types of and degrees of inflammation, and environmental factors. Now, phenotype is defined by the rate and extent of beta cell loss, regardless of the type of diabetes. That's why I'm submitting that there's only one diabetes, all diabetes. And the traditional view is that there's an inexorable loss of beta cells. You can see this on this dotted line here, right? And When you get to about 50-60% loss of beta cell function, you engender, quote, prediabetes. And when you get down to 80% loss of beta cell function, you have all diabetes. Now, in an article I just published this year, you should look for my proposal that we should change the diagnosis of diabetes from the fasting 126 plus prandial 200, glycohemoglobin 6.5 to pre-diabetic criteria, because these processes of damage to tissues, we'll talk about in a second, starts in the pre-diabetic range. Half of pre-diabetics already have heart disease, and 20-30% already have signs of eye, kidney, nerve disease. And another article I published in the past year, retinopathy, we say, starts before an ophthalmologist can ever see it with their routine techniques. So as I say, if there's a retinopathy in prediabetes of 25%, it's probably higher, because the neuroinflammatory processes the ophthalmologist can't see start before you even have your first microaneurysm. But we should also now start thinking about disease modification, beta cell function, and mass. And we'll do that by avoiding agents that destroy beta cells. You'll use agents that preserve beta cells. There'll be newer and fewer agents to increase beta cells, and we might be able to avoid the need for insulin. The blue graph on the right is the story about avoiding agents that destroy beta cells. That's was a slide created by DeFranzo. He showed that all the sulfonylureas work, very quickly. The first year you have maximal benefit on glycohemoglobin, but over the next 2, 3, 4 years, they lose their benefits. They cause beta cell apoptosis, which is my argument for not using sulfonylureas anymore, right? And there's data, and I published an article that they also increased the risk of adverse outcomes, cardiovascular outcomes.